Tau, the left ventricular diastolic time constant, is the gold standard index for describing diastolic function. As of 2026, non-invasive measurement of tau has been commercially available in China for 9 years. In contrast, in the United States, tau has largely disappeared from routine clinical practice. In this video, I will address 3 fundamental questions. Question 1. Why has our tau method not been published in mainstream journals? Over the past decade, several researchers, including myself, have repeatedly attempted to publish non-invasive tau formulas in major cardiology journals. Most of these attempts were unsuccessful. There are 2 primary reasons. First, the development of tau formulas is fundamentally mathematical. After years of advocating for tau, we must acknowledge a difficult reality. Most clinicians and many journal editors are not comfortable evaluating mathematical derivations. Second, some experts do understand the mathematics, but choose not to engage. This reflects institutional inertia. The so-called Harvard method of tau was proposed by prominent researchers from elite institutions, published in leading journals, and later incorporated into ASE textbooks and guidelines. Introducing a mathematically correct but contradictory method would be disruptive and professionally uncomfortable for some established figures. For this reason, I stopped submitting tau manuscripts for many years. That changed in early 2025 when JACE, the Journal of the American Society of Echocardiography, announced a special issue on diastolic function. I believe that a manuscript focused on tau, the gold standard index of diastolic function, could not reasonably be rejected. I was mistaken. The manuscript was rejected for reasons that, even by objective AI-based assessment, can only be described as ridiculous and anti-intellectual. Question 2. Do we really need validation? We now live in the AI era. Independent AI-based analyses have confirmed what we already knew. The mathematical derivation of our tau formulas is sound. Despite this, many still insist on further validation, particularly clinical validation. In fact, non-invasive tau formulas based on both mitral regurgitation and aortic regurgitation have been published and validated, although only after repeated rejections. This again reflects a familiar pattern. Truly disruptive innovations rarely enter the mainstream smoothly. Here is my perspective on validation. When a formula is based on assumptions, validation is necessary to test whether those assumptions hold. However, when no assumptions are made, the demand for validation becomes philosophical rather than scientific. Mathematical laws are universal. They do not require clinical endorsement to remain correct. Our tau formulas are derived from pure mathematics without assumptions. Validation is philosophical here. There is another uncomfortable reality. The current validation culture in medicine is deeply flawed. With sufficient data manipulation, almost any hypothesis can be made to appear validated. The Harvard tau method illustrates this problem. Despite being logically flawed, it was validated by leading researchers at elite institutions and published in top journals. History offers a warning too. Consider the Harvard cardiac stem cell therapy scandal. For nearly a decade, thousands of papers reported successful validation of remarkable findings, until the data were ultimately shown to be fabricated. The key lesson is this: Clinical validation alone does not guarantee truth. Question 3. If tau requires MR or AR, does this limitation reduce its clinical value? In a teaching hospital echo lab, tau can be measured in approximately 20 to 30% of studies. In smaller clinics, this percentage is lower because the patient population is generally healthier. Yes, tau cannot be measured in every patient, but this misses the central point. Consider the Rosetta Stone. In 1799, during Napoleon's Egyptian campaign, the Rosetta Stone was discovered. It contained the same text written in 3 scripts, including ancient Greek and Egyptian hieroglyphs. Because scholars already understood Greek, they were able to decipher hieroglyphs, and, in doing so, unlock ancient Egyptian civilization. The Rosetta Stone was not a complete dictionary, but it was sufficient. Tau plays a similar role in diastology. Although tau cannot be measured in every patient, the cases in which it can be measured reveal essential truths, consistent with long-standing clinical understanding. Diastolic dysfunction occurs earlier than systolic dysfunction. Diastolic dysfunction often parallels systolic dysfunction, but is usually more severe. Most importantly, comparative studies show that nearly half of guideline-based diastolic assessments are inaccurate. Now, consider the implications. Multiple intensive treatment strategies are currently being applied based on these assessments. Is this acceptable for patients? Is it responsible for guideline authors to ignore these discrepancies? Tau is not obsolete. It was abandoned. If you have questions or concerns about tau and diastolic function assessment, I invite you to share them. Together, let us work towards scientific integrity, better guidelines, and ultimately, better patient care.